Okay, hi everybody, Dr. Stuflug here again. We're going to talk about vent settings and how I want you guys to start out figuring out your vent settings and setting them up. So I know that I got a 30-year-old patient coming back who's 70 kilos. Some of the machines actually let you able to program that in. When I go ahead and go to volume mode, I hit that in. On this machine, I have to confirm every button that I hit, so I did. It is starting it on ventilator mode for me. This is just showing the max pressure that it can do. We won't worry about the alarms right now. It automatically set my tidal volume at 500. That is a little higher than I like. I like 5 to 7 milliliters per kilogram. So I would actually set this 350, 400, let's just go 400. I like to set my respiratory rate at whatever adults are. Adults are usually 12 to 20. So let's set it at 12. My IE ratio, a normal patient, we're going to inspire 1 second and exhale for 2 seconds. If I have restrictive disease such as cystic fibrosis or morbid obesity, I'm going to have it, you can think of a squeezing of the thoracic area, so that's a restrictive disease. That means their exhalation is going to be a lot quicker. Then I'm going to set this to 1 to 1. Let's say I have COPD. Now I have an obstructive disease process going on. I need more time for exhalation so I don't stack breaths on them. I will change that for a 1 to 3. And on this particular machine, we can change the inspiration time to go to 1 to 1 or 1 to 3. Now this is just to get you in ballpark to start the ventilator. You make all the adjustments based on patient and their end tidal CO2 and their peak airway pressures once you're on there, because you don't know how bad their COPD is or any of that process. So normal patient, ASA1, I'm going to leave it at 1 to 2. PEEP, I want you minimally to always have at least 5 of PEEP on your patient. You can have 10, but I want you to have minimally physiologic PEEP, which is 5 centimeters of water. And this is how I would set up how I'm going to start my ventilator. Now, when I switch it over to volume mode, those things will still be in there for me. As you know, when we go to sleep, we go high flow and we go 100% oxygen for our denitrogenation, pre-oxygenation scenario. Now we get them on the ventilator and it's going there. We don't need to keep high flows. In fact, we want lower flows to save on our sevoflurane, to not feed all the adipose tissue, all our sevoflurane. We want to be able to wake this patient up. So we're going to go to lower flows. Now, did my patient come to me on oxygen? No, it's a healthy patient. They came to me on 21% oxygen. Let's give the patient air, right? Medical air. So if I want 2 liters flow, I can go ahead and do 2 liters of air and turn off my oxygen. This might make you a little bit nervous, saying we got to have some oxygen. Well, that's fine. I want you to remember 30% or less on oxygen delivery for inspired, unless the patient needs more, and that will be by the pulse ox. So 30% or less. Right now I'm giving 21%, so as ventilation goes, this will start dropping closer to 21%. If I need a little bit, I can always give a little bit. If I give, let's say 0.5, somewhere in there, let's decrease this by 0.5. Okay, keeping my flows to where I want. And again, we're going to base it on the pulse ox. I don't need, here's 40% oxygen. I don't want 40% oxygen. 30% oxygen or less, unless they're showing you by the pulse ox that you need more. So now we're done with our maintenance of our case. That means for emergence and induction are the same. 100% oxygen, high flows. As you can look at our emergence video, you'll see in there that Kelsey went ahead and decreased our rate, and that's what I want you to do. I was at 12, let's cut it in half. Then they're going to keep breathe. Well, when they start to breathe, we're going to see that our rate will end up being more than 6. Now we see that's one indication that, hey, they're breathing on their own. The other indication, Kelsey pointed out in her video, that you will start to see on the exhalation, you'll see that they have an inspiratory, we call it a Chiari cleft, but an inspiratory movement during our end-tidal CO2 waveform. When they start breathing on their own, we're going to go over to manual, and then we're just going to watch their tidal volume increase to where we want it. Textbooks say that we want 5 milliliters per kilogram, so at this we would want them to pull tidal volumes in the 350 milliliter range, and that would be one of our criteria for extubation. So I hope that was helpful in how to set up the ventilator and run your ventilator. Of course, during the case, you're always going to be able to make adjustments on your ventilator, adjusting to keep your CO2 between 35 and 45. And just to touch on that, when we are in the middle of the case, if I want to lower, I'm going to do all my adjustments on frequency first. Okay, let's say I get up to 20 breaths per minute and I'm still in the 50s for end-tidal CO2 during the middle of the case, and I'm not wanting to get them spontaneously breathing. That's what a typical adult, kind of the max of what they would breathe. At that point is when I switch over to increasing either the PEEP a little bit more or start increasing the tidal volume. And then when I decrease, going the same way. I want to do rate first. I don't want to get too much pressure going in patients for barotrauma. I don't want too little pressure for atelectasis. That's why the PEEP is going on. And I hope that is helpful to at least get some basics in maintenance of your case. Also the emergence and induction part with your ventilation component. Thank you.